of medicine has taken on new urgency and led to a lot of debates in this economy. So these are the kinds of complex challenges facing medicine in the societies in these regions, and this is a kind of hint at how those of us who are anthropologists and sociologists of medicine actually think of the institution of medicine and think of the kinds of challenges facing the institution. I show one more photo here. This is another painting, a friend of ours in Indonesia, in Yogyakarta, and it is about modernism in the following ways. For him, these are women who come from the urban areas into the rural, from the rural areas into big cities. And for him, he says, they're wearing the mask of modernity. These are traditional women, but who are wearing some of the masks of being modern. And it's a reminder of the kinds of challenges that we face. Okay, thank you. Mary Jo is now going to begin talking about a case study of the work that we're doing that will illustrate some of these issues.
Does anyone have any questions for Byron before we go on, or shall we just go on and try and hold the questions? Yes, okay. What I've been doing for the last 35 years is living in the tribe of the medicine. In 1976, I had my first post-PhD job in a medical school at the University of California, Davis. 7 years later, I went back to Harvard to help establish a social medicine department with Arthur Kleinman and Byron, in which we developed a program in medical anthropology. What is medical anthropology? It's looking at medicine as well as patients, but looking at medicine as a cultural system. And that's what I'm going to address today. However, we are not simply looking at beliefs and meanings and practice. We also look at the economy, the economic context in which medicine is practiced. And in this discussion for today, I want to raise some questions about 21st century clinical realities that come not only from my work in the United States, but also my work with my colleagues in Indonesia. I work very closely with the pediatrics department as well as with the psychiatry department and with people in medical education. And we ask these questions about how political economies of medical research and biotechnology shape the scientific imaginary in particular settings, as well as moral, ethical, and cultural worlds. And we ask how the distribution of medicine's material products and cultural products are related to the political economy in which medicine is practiced. When I speak about the oncology, pediatric oncology, this issue I think will become clearer. Who gets the latest technologies? How are those technologies managed? What form does the political economy of hope, which underlies so much of the research that goes on in medicine today, especially in cancer research and in the diseases that are recalcitrant to treatment, how is that managed in societies not only with great wealth, but also societies in which there are low resources? How much are you going to invest in medical research and medical experiments, experimental designs, research trials? How do the local and international ideologies about population health and individual rights to health and medical care influence professional and institutional responses to needs specific to particular societies? If you think about what has gone on in the last 50 years, we find a real public health, and of measures to reduce infant mortality, maternal mortality, and to increase the well-being of people in general. What we're seeing now is the extraordinary things that you just showed in your video, where can you make skin? Can you make a new organ? The kind of organ, the whole work on the development of organs and the development of nanotechnology as ways of delivering medicine really captures the medical imagination. Yet we need to speak about issues that affect the inner life of medicine. In other words, those who are involved not only in teaching but also in practicing medicine and dealing with patients, and in thinking about who they are, who they become as they go through medical education, as they go through clinical training. And in this globalized setting, we have an ethical issue to address. How do we manage the global medical commons? How are resources going to be distributed throughout the world? The knowledge is there, the industry is there, the capitalism is there, but who gets what? What are we responsible for as members of global society? The global medical commons might be a really good way to think about what are our obligations to the institutions of care and to our fellow global citizens. The medical imaginary is what clearly infuses excitement in medical students. Byron and I have the great pleasure of teaching students at Harvard Medical School, including a group that comes out of the MIT-Harvard mix, so the high-tech medical school within Harvard Medical School that's a combination of these two, health science and technology. And we find that thinking about the future, again, it brings me back to your video, thinking about the possibilities of the future is what makes medicine fun and really interesting and a reason to practice. So it's not just money, it's not just economics, but it really is that scientific enthusiasm, the many possibilities of the future. And so I find that is a really important concept to balance a more negative sense that sometimes the public has of what medicine is all about. When we look at what's going on in medical malpractice or the sullying kinds of practices that seem to be driven simply by market forces, where the economic gene is far more important than the genomic imaginary, these issues, I think, come up. Why be a doctor? What are the purposes for actually entering that profession? The biotechnical embrace is a concept that I developed as I was working with medical oncologists and radiation oncologists who were enthused by what the possibilities were as they were working with dealing with AAL in children, acute leukemia in children. We have an increasing ability to achieve a cure. And also with people who were working with women who had breast cancer, where the increasing ability to achieve a cure was occurring within their professional lifetime. When interventions become technically sweet, not necessarily achieving a cure, but improving the life that one lives to, beyond being overwhelmed by illness, that technically sweet intervention is something that has an affective dimension, both not for the clinician as well as for the patient. So the sense of being embraced by the technology gets back to what Byron was speaking about, where techne is very important. The affective, emotional dimensions of medicine are not simply in bedside manner or in the art of medicine, but are also in that technological intervention in the technical act there is caring. People usually make a distinction between the art and science of medicine, and there's a lot of rhetoric about that. But when you look at the art of that technology and the emotional attachment through the technology that the clinician has with the patient, it's a fairly interesting concept to see how this might work as making the kinds of 21st century doctors that we are making today. The political economy of hope is a more crass, I think, notion that grew again out of the work I was doing with oncologists, where I saw how the distribution of interventions were so related to whether or not there were financial resources, and I'll come to a case to discuss that as well. The concept of the clinical narrative is a concept that also grew out of my work with oncologists, both in the United States and in Indonesia, with a story that clinicians, physicians, nurses create for patients about their illness and about their treatment journey becomes actually inscribed over time on a person's body. The patient reads their disease in part through the story that the clinician is telling the patient. Now, when you don't spend any time with your patient, you're going to have perhaps no narrative. The technical act might be simply meaningless to the patient. But if you create a powerful story about what this journey is, then you also enhance the quality of caring and, I would argue, the outcome in treatment. And it's also more fun for doctors to work with patients and be engaged in that creation of a story and leading patients through their long journeys, usually with cancer treatment, with meaning, the creation of meaning. Today we see a great deal of dismay amongst many people who are in the profession, certainly in the United States and sometimes elsewhere, arguing that the power of the profession has disappeared. It's under attack. There is no more cultural authority. There is great difficulty in managing controlling one's work due to higher bureaucratic, technical rationality administration. Those people who have MBAs are being criticized by many people who are just MDs. Now the question is, really true? We see through these other dimensions, through the medical imaginary, through the biotechnical embrace, a certain dynamic power that is ever changing. And the cultural authority and power of the profession may be changing in terms of its nature as we move through the 21st century and into these next decades. It is not this old version of controlling the shop floor necessarily. The definition of what a good doctor is has undergone a certain degree of change, and who decides that has undergone a change as well. The issue of medicine in transformation also raises questions about the moral voices. We saw, as the 35 years I've been working in medical schools, a kind of rhetoric that is taught to clinicians about the moral parts of practice. And yet the challenges today go beyond the doctor-patient relationship, go beyond the ethical issues of beneficence, do no harm, patient autonomy, the kinds of things that come out of the West,